Jaime Seeman, thanks for coming on the podcast.
Hey, thanks for having me.
Or should I say Dr. Fit and Fabulous? Or should I say Miss Nebraska? Or should I say Crusher of the Titan Games?
Take your pick. Depends what day it is.
She's got some accolades. So, okay, tell me this. What was it like being on the Titan Games with The Rock?
Okay, so it had been 13 years since I had competed at anything. So on a very personal level, it just totally ignited that competitive fire inside me again, just to be in this arena and, there's like a stadium of people. Oh, but then there's Dwayne "The Rock" Johnson. So no pressure. Honestly though, we really only interacted with him when we filmed our competitions, but you're out there competing, right? So it's not like you're over there fanboying The Rock, but he's super nice. He's exactly what everybody sees on TV. He's big. I'm not sure he's quite as tall as the internet lists him, but he's wide. Like his biceps, I think, are as big as my legs are. He's just a big guy, but he's super nice, and it was a cool experience. I mean, the people on the show were, the people that I met, I'm still in contact with a lot of them, and it was just a cool experience. Once in a lifetime, let's be real.
Yeah, it seems like it was definitely once. It's an amazing thing, and I was so stoked for you. And is there like a second episode? You won your heat, right?
So I finished top 6. I made it to the regional finals. I didn't win the show, and the only person that comes away with a monetary prize is the person that wins $100,000. Everybody else just gets the pride and glory of being on the show. And everybody was asking what's next, but I went on to win Mrs Nebraska. So now my focus really is on Mrs America, which talk about swinging the pendulum from like one end of life to the other in just a couple months. But I'm proud to represent the meat-eating women of the world. I met actually one other person on the show during filming who's very carnivore, which was so cool. We were nerding out in one of the break rooms with our plates of meat. He's an opera singer, and it was a cool experience.
That's amazing. Yeah, you are kind of the champion for all of us meat and organ eaters. It's amazing. And in case anyone didn't listen to the intro to this podcast, Jaimee is a board certified OBGYN. We've got a OBGYN doctor here who is crushing it in so many different realms. But as much as I wanted to hear about all the Rock gossip and Miss Nebraska gossip and Miss America gossip, what we're really going to talk about today is all the experiences that you've had with women over your career as an OBGYN and your perspective on these. So let's just start there. Let's just jump in. So I thought we could do this along the life cycle. And this is going to be a podcast aimed at fertility for women, but men have women in their lives. So it'll be relevant for you guys too. I know it, because I know there are men listening to this who are married, who have girlfriends, who want to conceive or are thinking about having babies in the future, or men who are married to women who are going through pregnancy or postpartum, or at the end, we'll get to the sort of perimenopausal or menopausal stage. So let's just start with the beginning, or, a woman's reproductive fertility, and talk about how you think about fertility and infertility in your clinic from a dietary or lifestyle perspective. Let's start there, and then we'll progress through kind of the pregnancy spectrum.
Yeah. So what's interesting about women is we are born with all of the eggs or the oocytes that we'll ever have in our lifetime, which is different than men who continually make sperm, right, and go through spermatogenesis. So a female baby is born with about 1 to 2 million oocytes in the ovary. And by the time they start menstruating, there's only about 400,000 left. And then women only menstruate about 1% of their eggs, which is like 400 to 500 menstrual cycles in their lifetime. So once a girl goes through puberty and gets into these years of fertility, this is when we're releasing these 400 to 500 eggs. And essentially what's happening every single month is the brain is stimulating the ovary to make a pool of follicles. So I kind of explain it like it goes into this room where there's this party going on, and it's like, okay, who wants to come to the party? I need the 20 best people in this room. And then at the time of ovulation, which is essentially 2 weeks after the last period, cycle day 14 in a perfect world, if a woman had a 28-day cycle, then one of these eggs gets released. It's like the chosen one, you know, essentially. And then if it doesn't get fertilized, then the whole process just starts back over. So in a woman's body, when you're in these years of fertility, the body is constantly taking a survey in the environment if this is a good time to reproduce or not. So we have these nutrient sensing pathways, and there's so many different things that can disrupt these pathways. And if the body perceives that it's not a good time to get pregnant, whether there's a lack of calories, right, and a reduction in thyroid function, whether there's fluctuations in cortisol, circadian rhythm plays a huge role in what's going on in this process. There's any disruption here, a lot of times the body will just choose not to release an egg. Or it may release an egg, but there's poor progesterone production from the ovary, which would help support an early pregnancy. So there's so many things that can go wrong in here. And I think women kind of take this for granted because when we're young, I myself included, we can get away with a lot of bad habits. And then suddenly women are in my clinic and they thought it would be easy to get pregnant, right? Or just have unprotected intercourse and pregnancy happens. We see it all the time, right? Teenagers getting pregnant all the time. But humans are actually, when we compare ourselves to other mammals, are actually really horrible at reproducing. It's interesting when you look at it that we ever make human babies, especially in the last, what we've seen in the last, 30 years, but even in the last 10 years, as I've gone through my clinical practice, we're seeing rising rates of infertility. Which is super scary. And it's not just women. You're right. There's men listening. And I want men who are listening to hear that male factor infertility is really going up. And women always think it's them. They always come in and say, oh, there's something wrong with me. I've been trying now for 12 months to get pregnant and I can't get pregnant. But when we look at what I would call like a normal healthy couple, the chance of conception each month is only about 20%. But when we look at normal healthy couples by a year, by 12 months, about 85 to 90% of them will be able to conceive. So we call the clinical definition of infertility not being able to conceive in 12 months of unprotected intercourse. So when a patient comes in and we are asking why this person can't get pregnant, there are a couple things that we look at. When we look at the causes of infertility, so about 15% of couples are affected, like I said, 85 to 90% would be able to get pregnant by that 12-month mark. About 40 to 50% of the time, it's actually male factor. So when we do a workup for infertility for men, it's pretty simple. We send them for a semen analysis and we ask them to produce a specimen with no prior ejaculation for 72 hours because you can actually deplete sperm counts if couples are having intercourse every day. So we get this specimen after a couple of days and we take a look at a couple of parameters. We look at how many sperm are in the specimen. We look at the concentration, which is the amount of sperm per milliliter in the specimen. We look at other factors in the specimen. Is there like white blood cells that may tip us off that there's some kind of infection, other cells that we don't normally see in ejaculate. And then when we look at the sperm, we actually see how many are moving. We call that motility. How many are moving actually in a forward progression. We call that forward progression. And then we look at morphology. So how many of them are actually shaped the correct way. And what's crazy is that men will have we want at least like 20 million sperm in a specimen, but men will have statistically usually low morphology. So when we quote couples on how many percent of the sperm do you need to be normally shaped, we like 14%, but actually most couples could probably conceive with 7%. And that's crazy to think that there's millions of sperm and only like 7% of them are shaped normally. What's going on here? And we notice if we look statistically from a historical perspective, there seems to be somewhere in our evolutionary pattern kind of this bottleneck that happened, and our semen started actually getting bad. And now it's getting even worse because, and we'll, of course, we can dive into this because of poor nutrition. But so 40 to 50% of the time, male factor infertility. And then because I'm a women's health specialist, I care about female factor, and that's usually somewhere in the ballpark of 30 to 40% of the time. And then we have this, basically what we call unexplained infertility, meaning we check the semen analysis, it looks normal. We do a complete workup on the woman, that looks normal, and then we just call that unexplained infertility. And so let's dial back to female infertility. So when I have a patient in my clinic and let's say we've checked the sperm and semen analysis looks great, there's kind of 3 areas that I think about. So the first one is structural causes of infertility. So these would be problems with the uterus or problems with the fallopian tube. So this little egg that gets released every single month has to travel down the fallopian tube. It typically will meet the sperm in the fallopian tube. So sperm can live anywhere from 3 to 5 days in the tube. So we actually want the sperm to be there before the egg gets released. But it will typically get fertilized in the tube and then travel down and implant. So things like tubal disease, if they've ever had pelvic infections, or just problems with the tube, something we call hydrosalpinx, where the tube is really dilated. And then problems inside the cavity, so polyps, fibroids, other structural things. So we can do ultrasounds, we can put fluid into the uterus. There's a lot of different ways that we can evaluate structural causes of infertility. And then the next one we think about is a common condition called endometriosis. And this is a condition where the lining of the uterus actually gets outside of the uterus, and it creates a very hostile, inflammatory milieu, and can cause a lot of scarring, localized inflammation, and that unfortunately is a very difficult disease to treat, and causes infertility for a lot of women. We don't really know the exact origin. There's lots of theories as to how endometriosis gets there, whether it, effluxes out the tube, but we know that's not true because there's case reports actually of endometriosis in the lung cavity and even in the brain cavity. So some people think it could be something embryologic because of the origin of those tissues. So endometriosis is another cause. And then the last one is what we call oligomenorrhea or amenorrhea. And this is back to where I was talking about how the body is sensing constantly if it should release an egg. And there's a lot of steps that have to happen for good follicular development and release. And this is where I come in. This is where I think things like lifestyle interventions and treatments probably tend to be the most successful. And the biggest one I deal with is PCOS, or polycystic ovarian syndrome, which at the most basic level is insulin resistance of the ovary. And that's a common reason for infertility that I see in my clinic. And then another one is maybe they're ovulating, maybe they're actually having regular cycles, but they have what I like to call estrogen dominance. So they tend to have a lot of estrogen and either a lack of progesterone or, well, it is a lack of progesterone either way, but they may be overproducing estrogen in relation to progesterone, or they may just not be producing progesterone that well. And progesterone is necessary to support that egg until it gets fertilized and implants. And so this is kind of the place where I can probably have the most influence in helping women achieve a pregnancy. And then when we think about unexplained infertility, my personal thoughts about this is these nutrient sensing pathways, there's probably likely micronutrient deficiencies that we haven't teased out. These women could be over-exercising or overstressed and still look normal from a biomarker standpoint. We think about toxins or endocrine disruptors in our environment, and I think that's kind of underplayed in infertility. And then, other things like caffeine use, smoking, marijuana use. There's other things that can definitely have an impact if you don't ask the questions.
That's amazing. So many different pieces there. So as you were talking about the male infertility, I was reminded of a study on the blue zone, specifically on Loma Linda. Have you seen this study on the sperm quality of males in Loma Linda? I'll try and pull it up real quickly as we're recording. But this is a really interesting one because it's one that I mentioned in my book. And, you know, as Jaimee was talking about, there is a lot of consideration of the sperm count and the sperm motility. And what they found in the males in Loma Linda, which is a primarily vegan and vegetarian community, which is Seventh-day Adventist, was that the males who were vegan and vegetarian had much worse sperm counts and much worse sperm motility than the males who were eating meat and omnivores. And there are a lot of hypotheses to explain this, but I think that you hit on it. And I think that a lot of fertility for males is, again, based on just nutrient adequacy. If you don't get enough zinc, how are you going to make your sperm properly? We know this. We know that semen contains a lot of zinc. I think there's like 2 to 3 milligrams of zinc goes into every ejaculate of semen. And so if a man is zinc deficient, you're not going to be able to be fertile. And there are many nutrients that come into play. And we're right back to nose to tail eating of animals and the nutrients in those. So that was the first study that I thought of. And then as you're mentioning the female causes, the other thing that I thought of was that I've seen women, I don't know if you've experienced this in your practice, but I've definitely seen women with endometriosis get a lot better with dietary shifts. And I'm not a specialist on endometriosis. I'm not a fertility specialist, but endometriosis has always made me wonder, is this an autoimmune thing in some way, or is this connected in some way with immunologic triggers, like so many of the other immunologic triggers we see improving when people eliminate things from their diet? One of the reasons I think a nose to tail carnivore diet or a carnivore-ish diet or a diet like these that eliminates plant foods, lectins, wheat, grains, beans can be helpful is from this immunologic perspective. So that's really cool too. I've definitely seen women with endometriosis improve there. We're going to get more into PCOS. That's kind of your I was going to say bread and butter, but you know, that's your steak and eggs.
Well, and I think with endometriosis too, when you think about a carnivore diet, it's a ketogenic diet, right? And so we know that the presence of beta hydroxybutyrate in the bloodstream inhibits the NLRP3 inflammasome. So for a condition like endometriosis, it's extremely inflammatory. Inhibition of the NLRP3 inflammasome probably is going to improve symptoms for these patients. Does it cure it? Probably not. I think there's a lot of things we don't know, but I think that's probably, why those patients tend to feel a lot better.
Yeah. And then I'm sure you're familiar. I think we've talked about this before, the biocycle study looking at the percentage or the incidence of anovulation. And it was at least correlated with more fiber, that the women who ate more fiber had higher rates of anovulation. I thought that was interesting. Again, it's a correlation. It's an epidemiology study, but it makes sense that excess amounts of fiber could be interrupting the enterohepatic recycling of estrogen or other hormones in the gut and leading to anovulation for some women. What do you think about that one? Are you familiar with that study?
Yeah, so there's studies on vegetarians and vegans who eat more fiber and actually drive their estrogen so low that it causes anovulation. And when we think about estrogen in the body, this will get down into the weeds a little bit for anybody that doesn't understand estrogen or physiology, is that estrogen is an amazing hormone for women, but it's a hormone, like I like to describe it as use it and lose it. So we want it to go around and do its amazing things in our heart and our bone and our brain and in our skin, because we have estrogen receptors everywhere. But then we want our estrogen to go back to the liver, where it goes through phase 1 and phase 2. I hate the word detoxification, but metabolism, whatever. But then the third phase is actually in the colon, and something called beta-glucuronidase. Essentially, if you have high enzyme activity, it can actually unpackage estrogen and cause recycling, which for somebody who is, estrogen dominant, this is a real issue if you're reabsorbing your estrogen and continually recycling it. But it can swing the other way. Everything's a U-shaped curve, right? And so if we're not recycling any of it and we're just pooping all of it out and we drive our estrogen super low, that can obviously be another reason for infertility. And yes, I completely agree with that.
The dangers of excess fiber. They never stop. Fiber never, the gift
more
that.
Is not better.
Yeah, more is not necessarily better. I would agree with you there. So you mentioned PCOS. Maybe we should dig into this one a little bit because it's something that you have an interest in, and it's so connected with insulin resistance, metabolic dysfunction. But in your practice, what percentage of infertility do you think is related to polycystic ovarian syndrome?
Well, I think when you think about female factor infertility, it's huge. It's huge. It's probably, one of the most common things that I treat. And now I take care of a lot of patients who, just within my community are very like low carb driven, and come to me for their PCOS. So who knows compared to my colleagues how much they really treat, but I take care of a lot of women, and in my clinical practice, anecdotally, have been able to get a lot of women pregnant just off nutritional strategies. A few of them I've had to use oral ovulation induction, but I've had a ton of patients get pregnant just with changes in diet. And when you look at the studies on PCOS, you're going to see all sorts of interventions, birth control pills, spironolactone, other, aromatase inhibitors, all these things to help the symptomatology of PCOS. And that's fine and great. But the problem is you're not treating the root cause. And do we know what the root cause is? I don't know, because we certainly have this spectrum of disease, right? Skinny PCOS patients are the ones that you really, start to scratch your head with, because, certainly the obese ones with androgenic symptoms, it makes sense, right? That there's insulin resistance, but the ones that have good actual peripheral insulin sensitivity, but seem to have insulin resistance to the level of the ovary, are the ones that are a little harder to treat. And so there probably are some nuances there that we don't understand. But PCOS, if I had to put $20 down in Las Vegas, for most of my patients who are oligomenoreic, putting them on a low carb diet, a lot of times will get them to spontaneously ovulate again.
Do you ever think about linoleic acid? That's been on my mind so much. As you're talking about these women with skinny PCOS, I wonder what their linoleic acid levels are in the blood or at the red blood cell. And we can't do this yet, but I would love to see what the size of their adipocytes is. The adipocyte hypertrophy versus hyperplasia is something I've been thinking about a lot. And I just wonder if that might be something that's going on there.
Yeah, no, I think it's something to consider, because I've had patients who are the skinny PCOS phenotype who have been on a low carb or ketogenic diet, and their numbers look good and they still can't get pregnant. We can't get them to have regular cycles. So there's definitely more to it. And of course, everybody knows there's a million ways to do a ketogenic diet, and you could be eating lots of canola oil or vegetable oils or things like that, bacon. There's lots of ways to do it. And so I think there probably is an optimal way when we think about fertility in particular and these nutrient sensing pathways. I think there's something definitely there to look at, but we just don't have, great data on it.
If you end up thinking about that in your practice, I would love to hear that information. I would be so interested to hear if there is, at least observationally from what you see, any sort of correlation with red blood cell or serum levels of linoleic acid or any of these other factors in these patients who have skinny PCOS, because you have your own story with this, and we talked about it. Just in case, I guess I didn't say this at the beginning of the podcast. This is the second podcast that Jaimee and I have done. You guys can listen to the first one. In the first podcast, we talked about ketogenic diets in relation to hormones. Most people listening to this will know that I've been kind of interested in this idea of, do carbohydrates cause insulin resistance per se in all people, or is there something else lighting the fire? But you had a story about this personally too. I don't know if you had infertility, but you certainly had improvement in your physiology and body composition when you went to a low carb diet, right?
Yeah. So when we tried to get pregnant with my first daughter, I was actually a medical student, and I was oligomenoreic. So I had come off years of birth control use. And as another kind of aside, birth control pills, in particular, combined oral contraceptives, or for that matter, use of combined estrogen and progesterone, vaginal rings, patches, you name it, any birth control that contains both estrogen and progesterone is actually well known to deplete the body of B vitamins, zinc, selenium, magnesium, and cause low level oxidative stress. So here you have a patient who has had PCOS, which I was, basically told I had PCOS. I have had issues with acne over my lifetime, but I was on birth control for a long time. And when I came off of it, here now you have a person trying to get pregnant that's probably micronutrient deficient, on a basic level. So is it the PCOS? Is it micronutrient depletion? Hard to say, right? But we tried actually for 9 months to get pregnant and couldn't get pregnant. And our doctor was at the time willing to consider doing oral ovulation induction to start my cycles. But I actually went on metformin for 1 month. And I, come from a long family history of diabetes, but nobody ever checked a fasting insulin. Nobody ever checked an A1C. I was a med student. I wasn't eating great. I'll fully admit that. But my doctor said, why don't you try to lose about 10% of your body weight? Because that's what we tell people with PCOS. So this is what I literally did. People are going to be like, oh my God. I was in another town on a surgical rotation and I could eat for free at the hospital cafeteria. And so the easiest thing for me to do was I literally took an iceberg lettuce salad and I put cottage cheese on it. And I ate like lettuce and cottage cheese for like a couple of weeks straight. I lost about 10 pounds, came home the next month and I was pregnant. So metformin, lettuce, and cottage cheese.
There's the answer. There's the answer, ladies. No linoleic acid, metformin, lettuce, and cottage cheese.
Yeah, and it worked. It worked.
We're joking. We're joking. That's not the answer. It's not.
I think I had some chicken, but I definitely wasn't eating beef or eggs. So I got pregnant, failed all my glucose testing, developed hypothyroidism, and then went on to eventually develop prediabetes. And that's when I decided to kind of change my life. But that's basically my story. And for me, when I first started on this journey, it was really like figuring this out for myself. And now what's been so incredible is to help other patients do the same. Like it's so rewarding to not have to use medications and to watch these women do things on their own. And we are certainly kind of, in uncharted waters. But one thing, back to what you were saying about polyunsaturated fatty acids, we do know that from a fertility perspective, increasing omega-3s in the diet, or DHA, can be helpful for fertility. So for ovarian health, omega-3s and DHA actually help with follicular development. And egg development. And then for men, it increases sperm motility. So that can be something that can help with sperm motility. And I think anytime you say, let's increase this in the diet, I think that people naturally replace something else in the diet. And so, it could be that we're starting to change the percent of omega-6s in the diet for more omega-3s. And maybe that's what's helping with ovarian follicle development.
Yeah. The one thing I'll mention there is that I think it's very interesting when we're asking people to increase omega-3s, whether we're making that and a piece of advice that is in tandem with decreasing omega-6s. I think that's the most important thing. And what I've at least observed in my clients and personally and in my research is that if you decrease omega-6s, your body will make more omega-3s. I don't really supplement with omega-3s at all. I get all of my EPA, quote, DHA, and ALA, which is alpha linolenic acid, from the meat that I'm eating. I actually have done kind of even low egg yolks the last few months as an experiment. And on one of my other videos, I actually showed my fatty acid levels, and my EPA is extremely high. My DPA is robust. And I actually have a pretty moderate amount of ALA, alpha linolenic acid, despite eating no plants. And I think that the reason that that's happening is because when I don't inhibit all of those desaturase and elongase enzymes that are shared between the omega-6 and omega-3 sort of synthetic pathways, your body can actually turn ALA, which is found in animal fat, into EPA and DHA. And I personally wonder if a lot of the omega-3 deficiency we're seeing is because the omega-6 in the diet that's excess linoleic acid is kind of gumming it up. I agree that for a lot of people, omega-3 supplementation can be helpful. I worry personally about excess omega-3 leading to lots of polyunsaturates, which have to be controlled from an oxidative perspective. So at least from my perspective, I would say if you're going to do omega-3 in your diet, make sure you decrease the omega-6 also, and realize that really well-fed animals and well-fed animal fat is a pretty great source of omega-3. Would you agree with those things?
Yeah, 100%. So when we're thinking about fertility, I tell patients, increase fish, increase beef, look at butter, ghee, these other sources.
Tallow.
But I think people naturally replace it. I don't think they're eating, I think, I don't specifically tell, I mean, I specifically tell patients to avoid canola oil, vegetable oils, like, these types of things, but natural sources, like nuts and things like that, I find that patients will naturally kind of trade some of those fats, but.
Yeah. And you brought this up, so let's just talk about this a little bit for women. What do you think about birth control methods? I love that you mentioned that the hormonal birth controls, and there's so many that contain estrogen, these rings, even IUDs, the oral contraceptive, combined pills, progesterone, estrogen, the single hormonal birth controls. I love that you said this. So thank you and I'll just reiterate, these are going to deplete magnesium, minerals, selenium, and B vitamins. We're kind of working against, which is, again, in my opinion, more of the importance for nose to tail animal foods in the human diet. What do you think? So if a woman wants to have control over her reproductive cycles, how do we mitigate this? Is it just attention to eating better, eating organs while they're taking these birth controls? Are there other ways to control fertility that would not be as depleting of these nutrients? What do you think?
Yeah, so just to start with, birth control is amazing. Birth control allows women to decide when they want to be pregnant and when they don't want to be pregnant. So,
Right.
so all in all, as a women's healthcare provider, I'm a huge fan of birth control because, as we know, about 50% of the pregnancies that we encounter are unplanned. And these are people who are not healthy, shouldn't be having babies. It's just not the right time in their life. So birth control is great. But, anytime we change a woman's physiology, it comes with ramifications. And so, when we think about birth control, there's really kind of three categories. So there are non-hormonal birth control options. So this is, of course, like natural family planning or, cycle mapping. Basically, it's cool now with smartphones because everybody can track on their cycles and they can track their basal body temperatures and their cervical mucus and all these things. And you can either avoid intercourse in your fertile period or you can use barrier methods. There is a non-hormonal IUD, it's a copper IUD, but with that one, we have to think about the copper and zinc in the body. And especially if we're gonna, take out the copper IUD and you wanna get pregnant, we wanna make sure you have adequate zinc levels. And then the next one is the combined contraception. So these are pills, patches, and rings, and these have been shown in the data to deplete B vitamins, zinc, selenium, magnesium, and cause low-level oxidative stress. So from this standpoint, if you're on these, and clinically what I see, and I have been on a birth control pill before, is women feel horrible. You put them on a birth control pill, they just feel sluggish, they get brain fog, some of them get gastrointestinal disturbances, they get headaches, their libido goes down. I mean, women do not feel good on birth control, and a lot of people think that's just like how they work. They just make you feel crappy, like you're not going to want to have sex and have a baby. But that's not how, I mean, they're supposed to just inhibit ovulation, right? They're not supposed to make you feel horrible, but they come with side effects, and they start to drag on the thyroid. And like I said, the problem is a woman takes that birth control pill up until the month she wants to get pregnant, and then she comes off of it, and here she is with micronutrient depletions, probably subclinical hypothyroidism. And so, yes, a woman who is on these types of contraceptives needs more than the recommended daily, allowance of B vitamins, zinc, selenium, magnesium, vitamin C and E, and their diets are not optimal. They're not optimal. Can you supplement? Yes, and we can certainly dive into prenatal vitamins and supplements and things like that, and how they're a good idea, but they're not perfect. And then the last form of birth control is progesterone only. And this is where I'm a little bit biased. Things like long-acting reversible contraception, like progesterone IUDs, because it avoids the use of systemic estrogen and estradiol. But they do come with side effects too. So the most common progesterone IUDs contain levonorgestrel, which can be androgenic for some women. I've had some women trouble losing weight on them. I've seen women who have experienced issues with hair growth or acne exacerbations using these methods, but I'm a little biased towards the IUDs. The user satisfaction rates for patients is super high. So that's probably the most commonly prescribed birth control in 2020 is IUDs, intrauterine devices. But it's really a woman's personal choice what she wants to use. And so we just, like any doctor, right, we have risk and benefit and an alternative discussion with the patient. But I do remind patients, especially my ones that choose oral contraceptives, that your diet needs to be good, or you need to look at supplementation of some of these things, especially if you are, planning a future pregnancy. And that's the unfortunate part, is most women don't think about that. They just call the doctor after they get pregnant. We wish that more patients came for preconception visits to talk about optimizing their diet, because micronutrient deficiencies can take, it's not an overnight thing. They can take like 4 months sometimes to get yourself back into an optimal level. It's not a quick fix.
Well, let's talk about that. If a woman were to come to you, or a couple were to come to you and say, hey, we want to get pregnant in 6 months, what can women be thinking about to optimize their diet, optimize their nutrition in that prenatal period before they start trying to conceive? And I love that you mentioned, if women are on birth control for years and years and you get off in 1 month, you might have nutrient deficiencies, which will kind of play into the same idea.
Yeah. So when we think about, fertility in general, you had mentioned zinc previously. So for men, zinc, super important to get extra zinc in the diet, especially, when you were talking about the milligram of zinc, like per ejaculate, these couples, right, are having sex multiple times, could be multiple months. So you need almost excessive amounts of these things to be available. So zinc is super important for testosterone levels and for cellular division, not in just men, but in women as well. And then I talked about DHA and how this was super important for ovarian follicular development and for ovulation. And so what I do with my patients is I ask them, what are you eating? Like, give me an idea what you eat on a regular basis, or I do a 24-hour dietary recall. And I kind of try to estimate for myself, where they're at with their diet, what they could be lacking in their diet. And of course, what I find with most patients is like a standard American diet. A lot of them are consuming 50% of their calories from carbohydrates. And like I had mentioned earlier, anytime you eat something in the diet, you typically replace something else. And so what we're doing is eating more fortified grains and cereals and things like this, and we're eating less nutrient dense animal foods. And for women in particular, they're typically really bad at eating protein. I find for some women, it's like a texture thing. Some women do come with, ethical reasons why they eat maybe a plant-based or vegetarian or vegan, which we can totally get into, because I don't recommend for fertility. But I look at what they're eating, and then we talk about ways that they can change it to optimize, number one, their fertility, because optimizing your health prior to conception is what's most important for your pregnancy. You don't want to come into a pregnancy with nutrient deficits, because I'm telling you, that baby is going to suck the living life out of you. And then the other thing is super important for fertility is B vitamins. And so, like I said, the most common source in most people's diets is fortified grains. So when you think about historically with prenatal vitamins, actually what happened was in the 1970s, prenatal vitamin manufacturers started adding folic acid into multivitamins. And then in the 1980s, they realized by adding this folic acid that it decreased the risk of birth defects, specifically neural tube defects. And so that's where prenatal vitamins kind of got their launch. Well, B vitamins are super important for fertility. B vitamins, and B12 in particular in men, helps with sperm counts. So there's studies that show, supplementing with B12 helps sperm counts. And in women, if you go back, a few minutes in this podcast, when we talked about estrogen, estrogen has to go through phase 1 and phase 2 metabolism in the liver, and B vitamins are cofactors, super important in the way that we create estrogen. And that helps with ovulation and with embryo implantation. And then vitamin B6 in particular is important for the synthesis of progesterone. So we talked about estrogen and progesterone both being super important. Other things in the diet that are super important for fertility, selenium. Selenium in men creates faster sperm. Your sperm can swim faster, so selenium is super important for sperm. And in women, it helps with fertilization, and selenium is also directly related to progesterone levels. So making sure that you have adequate selenium. And remember, we said selenium is one thing that gets depleted by birth control pills. So this is one where we really have to look at what their selenium sources are in their diet. And then magnesium. Oh my gosh, magnesium. Everyone's magnesium deficient, and serum magnesium levels aren't helpful. I don't think they really tell us what's happening at the tissue level. And magnesium is used for thousands of different, as a cofactor for different processes in the body. And like I said, if I had to put $20 down in Vegas, most of my patients are insulin resistant. And magnesium deficiency actually further exacerbates their insulin resistance. So almost all my patients end up supplementing with magnesium if they're insulin resistant. And magnesium is another one that helps with progesterone production. So from a hormonal imbalance perspective, my patients that are oligomenorrheic or amenorrheic or just have that unexplained infertility, this is getting more magnesium in the diet is important. And then cholesterol. Cholesterol is what our sex hormones are made from. So we need cholesterol in the diet. And so, that comes from animal foods, beef, eggs, all great sources of cholesterol in the diet. And then when we look at protein, we talked about how women are bad at eating protein. Protein needs in pregnancy are increased. And so I like women to get used to eating meat and protein with their meals. And then things like arginine, which is also important for male sexual, not only sperm production, but sexual function, and same with women. So getting these adequate amino acids. So these are the things that are important for fertility. And of course, I don't go through each of these in clinic with the patient, but we basically look at what they're eating and we talk about ways they can improve, their diet. And it almost always includes taking out processed flours, sugars, vegetable oils from the diet and replacing them with nutrient-dense animal foods.
I love it. And, as I'm hearing you say that, I'm thinking, if you were to, many women or men listening to this might think, wow, that's a panoply of nutrients. Where do I get all those? You could use a synthetic multivitamin, which I'm not a fan of for many reasons. The forms of these vitamins and minerals, specifically the B vitamins found in multivitamins, are often not the bioavailable forms, or they're a little different. Folic acid actually doesn't occur in nature, and it's a form of folate that's not the same as methylfolate or other types of folate that are used by the body. And there's some even people who theorize that folic acid could block normal folic acid receptors and folate receptors, in the human body. There's no such thing as a folic acid receptor. So
especially if you're MTHFR, which
yes,
about 30% of patients. I found out I had it after the fact. Thank God I have normal children, but
yeah. If you have an MTHFR, which is methylene tetrahydrofolate reductase polymorphism, I have the same polymorphism. I did a previous podcast with Ben Lynch about MTHFR. One of the interesting things about MTHFR is if you have either the 677 or the 1298 polymorphism and your conversion of 5,10 methylene tetrahydrofolate to L5 methylfolate is impaired, you can get excess riboflavin or robust amounts of riboflavin, and that MTHFR enzyme will work normally. I'll put a paper in the show notes that shows this, but what's so interesting is that all of these nutrients are found in nose to tail animal foods. That's what's so interesting to me. You can get selenium, you can get magnesium. We'll talk about that one. You can get all the B vitamins. And if you leave out the organs, you're not going to get enough folate or enough riboflavin or enough biotin. That's what I worry about. Meat is super nutritious, but the organs are what complete the picture, and certainly what our ancestors were always doing. So if those nutrient recommendations sound overwhelming to people and you're about to reach for the multivitamin, remember two things. You can get all of that by eating like your ancestors, by eating nose to tail, eating good, well-raised meat and organs, which include liver and spleen and pancreas and all these organs, kidney. And secondly, that the forms of many of these nutrients found in multivitamins are synthetic and they're not quite what the body is expecting. I want to do more research on this, but I think there's actually chirality to the B vitamins, and there are enantiomers. There are optical enantiomers, and what ends up in a multivitamin is often both enantiomers, both sort of chiral centers of these B vitamins, and that's not what we're expecting in real food. So, and again, you guys, of course, if you can get the organs fresh, that's amazing. But if you can't, that's what we do at Heart and Soil. We make desiccated organs. So I want to ask you about this, Jaimee. A lot of people get worried about liver in pregnancy or liver in prenatal. Do you have concerns about excess vitamin A from liver? How much should people be eating? What do you think about that? Because liver is so nutrient rich, right? It has biotin, it has riboflavin. It's the best source of riboflavin. It has zinc, it has copper, it has these nutrients we need, selenium, all these things. But then women, I think, here in the mainstream, like, oh, liver oil causes birth defects. What are your thoughts on this?
Yeah. So quickly before I dive into the liver, I just want to make a comment about prenatal vitamins and what you said. I 100% agree. Most of the prenatal vitamins are synthetic forms of the vitamins and they're less bioavailable.
Right.
And some of them could cause harm. There are studies on unmetabolized folic acid. It can be
Right.
very dangerous. I mean, there's like studies that show teratogenicity and things like that. And when I first started at my practice, you know, I was taught as a resident to basically say, oh yeah, any cheap prenatal, like just go to Target and pick up a prenatal. As long as it has 400, you know, folic acid in it, you're fine. And then I got into practice and started looking at the studies and I was like, oh, I feel like I've been telling people the wrong thing. And I went into our, you know, supplement closet at the clinic and every single bottle of prenatal vitamin there had folic acid. None of them had folate. Like one of them had, I think, like actually both folic acid and methylfolate. And I was like, this is crazy. They don't have enough iodine in them. They sure as heck don't have enough choline. There's only so many things that you can shove in that capsule. And when you think about things like minerals, you know, like calcium, magnesium, these types of things, those are really bulky. And so a lot of times women are getting some prenatal, they have to take like 6 of them a day. And in the first trimester, they're nauseous, they can hardly stomach them. Oh, and they contain synthetic forms of iron, which are horrible for the gut. They cause constipation, they're not well absorbed. And so I want to use that as a segue into thinking about nature's multivitamin, which is of course liver. And then the other thing, when we talked about genetic SNPs like MTHFR, I also found out that I have a genetic SNP. I don't convert plant sources of vitamin A well. So most of them are not retinol, right? They're plant sources of beta carotene. And I don't convert plant ALA well. So animal sources of DHA are extremely important for me. And once again, thank God that I have normal children. But yes, when we think about liver, I pulled up a couple studies. So the controversy with liver consumption, you know, in pregnancy was raised by studies that showed that synthetic vitamin A led to birth defects. And we have never seen with naturally occurring vitamin A that it has a teratogenic effect, especially when it's consumed with other adequate things in the diet like vitamin D and vitamin K2. And so we cannot say that liver and vitamin A supplements are the same thing. So that's one thing that I want people to understand. Because liver truly is nature's, you know, multivitamin. Now, what's scary is that, back to the vitamin A thing, is that when we screen pregnant women, about 1/3 of pregnant women are actually borderline deficient in vitamin A in their diet at baseline coming into pregnancy. And plant sources of vitamin A aren't perfect because the conversion, like I said, is highly variable. And for somebody like me, and I don't test everybody for these genetic SNPs, but if you have a genetic SNP, plant sources of vitamin A are probably not going to get you where you need to be. And vitamin A is super critical not only during pregnancy, but during breastfeeding as well, because it actually helps with immune function and lung function in the baby. And so being inadequate in vitamin A, telling women that they can't eat, right? Because we mostly scare women away from eating like beef and liver and eggs and things like this that are rich sources of vitamin A. But liver in particular, like we said, also contains B12 folate, which is hard to get and super important for blood cell function, brain and nerve development. And then remember how I mentioned iron. So heme iron, this is a great source of heme iron. It's extremely well absorbed. It doesn't come with any constipation like iron supplements do. And it helps with brain development and growth of the baby. And then our fat soluble vitamins, right? So here's our vitamin A, but also our vitamin D, E, and K. So our other fat soluble vitamins, and they're not synthetic. It's from a natural source, and they're really well absorbed. And we talked about the difference between retinol, right? It's so plant sources have provitamin A that have to be converted, whereas if you eat liver, it's in the source that you need. I particularly for my patients, when we look at the recommended daily allowance of vitamin A in the diet, I think eating, you know, I tell my patients 1 to 2 ounces a day is probably perfectly appropriate. Or if you like to eat more than that, then just eat it a couple times per week. And that essentially will give you almost a majority of the nutrients that you need from a prenatal vitamin.
It solves all the problems. And I just think that that's exactly what our ancestors were doing. You know, they would kill an animal. The liver was sacred. It was distributed around the tribe and especially given to young men and women who were trying to conceive. these kinds of things. I love that you brought up iron. I was thinking about that one also. So spleen is the richest source of heme iron in the body. And there are so many women with iron deficiency anemia. People don't think about spleen. A lot of people are not going to eat spleen, which is why it's cool to like put it in a supplement. We just came out with one called Blood Builder, which actually has blood and spleen and liver in it. That would be a great sort of prenatal thing. But there's all these organs just make it so easy for people to get these things. They're hard for some people to eat, but for me, it's part of the remembering. It's a hearkening back to the way we've always eaten, and we've forgotten it. And then we end up with, you know, women with profound nutrient deficiencies, and it's all so simple to fix. It's so great that it's there. We just need to help women do it. So that's really interesting to hear you say that about liver, because I've thought the same thing, that there's really no evidence that liver occurring, that vitamin A occurring naturally in liver is going to be harmful for humans. The studies are all done with retinol palmitate, synthetic forms of vitamin A, which, as we've talked about with folic acid, could be behaving differently in the human body. And I love that you brought up the conversion of beta carotene, which many people call pre-vitamin A, to retinoic acid, which is the bioavailable form of vitamin A. The polymorphism is in BCMO. And, you know, one of the other things that was striking for me as I was writing my book was that if you look at beta carotene, because that conversion is poor in everyone, whether you have a SNP, which slows down the conversion or not, the studies that I saw suggested that you needed, I think it was 19,000 units of, or something. It was like the conversion was astronomical. So that even if you looked at sweet potato, which is the highest source of beta carotene in the plant kingdom, you would have to eat a pound of sweet potato per day to get the equivalent of the RDA, so the bottom end of the reference range for retinoic acid equivalents every day. I think a lot of people are vitamin A deficient, and you fix that immediately with egg yolks or liver or kidney, these other things in your diet. Those are what our ancestors have been eating. And to try and get your vitamin A from plants, I think is an adventure. You're not going to do it really easily because of that poor vitamin A conversion.
And I think I looked at one study, the more beta carotene you eat, it actually slows down the process. So it's mathematically impossible to get what you need trying to get it from plant sources.
And there are, I'll put a study in the show notes, there are isoforms of the beta carotene breakdown products that actually might inhibit vitamin A at the receptor, retinoic acids. That was really interesting for me and something I didn't know until recently, that beta carotene can be broken down multiple ways. It doesn't always get broken down into the retinoic acid that we use. And some of the breakdown products can actually inhibit vitamin A at the receptor. That's not good either. You don't want to get the majority of your vitamin A, quote, precursors from plants. You just want to get preformed vitamin A and preformed methylfolate and preformed B vitamins in the form the body uses it from animal meat and organs. It works so much better.
And, you know, so I tell patients, like, your prenatal vitamin is basically like an insurance policy, but your most bioavailable sources of nutrients should be coming from your diet. And like we said, there could be harm for some patients, you know, in taking them. Clearly, we made babies all the way up until the 70s and 80s without them. But because my patient's diet, you know, the vast majority of people, they don't eat like you and I do, right? Because their diets are so lacking, they probably are needed amongst, you know, a vast majority of our population. When it comes to liver, of course, not everybody is used to eating liver or nose to tail and those types of things. And so I have patients that do take desiccated liver supplements, but just like any supplement, you know, you need to know the sourcing, you need to know where it's coming from. The liver in particular filters toxins in the body. So, you know, ideally, if you can be getting it from a place where you know where it's coming from grass-fed, you know, ruminant animals, these are kind of best practices. So we do need to be important, or that is important, you know, when we think about supplementing.
And I just want to add there for people who may have heard the liver as a filter, that though the liver processes things for detoxification, it doesn't store them. Right. It exports them in the urine and the poop, and it has this phase 1 and phase 2 metabolism systems that we talked about earlier that prepare these substances. Some of them are hormones that we are getting rid of or excreting. Some of them are actual toxins in our environment. It excretes them. The liver doesn't store them. The liver's not like a shower filter or a drain filter in your tub. It doesn't hold on to things. That's not how it detoxifies them. It doesn't pull them out of the blood and store them. It pulls them out of the blood and prepares them for excretion. So don't fear eating liver, but as Jaimee is saying, absolutely get it from the best source you can, the cleanest animals that are grass-fed, grass-finished, regeneratively raised. So, okay, so we've talked about infertility, we talked about conception. If we talk about pregnancy, does anything change in pregnancy? Once someone has conceived and they're carrying a baby for 9 months, do you think about anything differently? It's probably a lot of the same stuff, but what do you tell those kind of women in terms of nutrition or support during that phase?
Yeah. So when we look at the physiologic adaptations that happen in pregnancy, in the first part of pregnancy, it's largely anabolic. So as soon as the woman gets pregnant, we see about a 30% increase in production of insulin from the pancreas. And this causes a lot of blood sugar dysregulation. Even my most low carb carnivore patients, I will tell you, Paul, because you've never been pregnant, first trimester can be brutal. It's a beast. And there's a lowered threshold for glucose stimulated insulin production as well. And so in the first trimester, I don't hammer on people as much for carbohydrates as I do in the second and the third trimester. But basically, this is an anabolic stage of pregnancy. We start to see glycogen accumulation in the liver, and we start to see our fat cells actually hypertrophy. There's an increase in lipogenesis and an increase in lipid storage. So it's likely, it's largely anabolic. But then when we flip into second and going into the third trimester, it becomes largely catabolic. So these are normal physiologic adaptations in a pregnant woman. We actually see a rise in both leptin and insulin resistance. So leptin resistance helps maintain that maternal appetite. That's where women get quote unquote pregnancy cravings. We want that pregnant woman to be hungry all the time because we want her to constantly be taking in food. But with that being said, when we look at the caloric needs in pregnancy, it's not all that much more. Depending on which trimester you're in, it might be anywhere in the ballpark of 100 to 300 extra calories per day. So this really isn't the time to be eating, excessive amounts of calories, even though the appetite is good. But what we start to see is a rise in lipolysis and hepatic gluconeogenesis in the second and the third trimester. And it's a normal state where we see both free fatty acids and glucose in the bloodstream. And this is basically nature's way of assuring that there is an adequate supply of nutrition that is readily available for that baby throughout the pregnancy. And unfortunately, if a woman comes into pregnancy with excessive amounts of carbohydrates, or what I call like abuse of carbohydrates, eating above her threshold, this is where we start to see the most complications. So not just gestational diabetes, but there was a trial called the HAPO trial, and we can dive into that if you want. But we're talking about hyperinsulinemia in pregnancy causes increased risk of gestational diabetes, increased risk of preeclampsia, excessive weight gain, and not only for the mom, but we for sure see epigenetic changes related to hyperinsulinemia. It increases the risk of her baby being obese, her baby being insulin resistant, developing type 2 diabetes and cardiovascular disease later in their lifetime. So, one of the things we say in medicine, right, is do no harm. And when I first came into, kind of the low carb world, and these pregnant women were coming to me and they're like, well, I'm only eating, 75 carbs a day. Can I just continue to do that? Well, of course, we don't have any data, and it's unethical to, study pregnant women. And so largely what I've seen over the last, few years is really just observing these women, and they have healthy pregnancies, they have healthy babies. And in my gestational diabetics in my clinic, not type 2 diabetics, but gestational diabetics, I have had to put 0 gestational diabetics on medication.
Amazing.
None. We've been able to monitor it and control it with diet alone. And I use continuous glucose monitoring for a lot of these patients now, which is awesome. And I really think it helps them. But it's the normal physiologic adaptations do not help the majority of women who are eating a standard American diet. For the patients that are eating more low carb and carnivore, I feel like they tend to feel better throughout the pregnancy. They tend to gain less weight. And they tend to have, less problems postpartum. And when we look at, survival of human babies. Ketone bodies maximize survival both in utero and in neonatal life. This continuous glucose drain by the fetus actually converts the liver into a ketogenic organ in the third trimester, and ketones do cross the placenta. But we have been, told that it's pathologic. And one of my biggest pet peeves is when I used to send patients for gestational diabetes education, they were making patients check their urine ketones. And urine ketones do not correlate with serum ketones, and it drives me nuts, which is why I stopped sending them and I just started doing my own education, and it takes longer for me. This is not efficient use of my time as a clinician, I'll just tell you that. But deep down in my soul, I know it's so important for this patient sitting in front of me. So I do my own education, and I take care of my own, gestational diabetes. There's a lot of OBGYNs around the world that just send them to like a gestational diabetes clinic, or, so be it, but they get bad information. And so I keep them in my clinic.
It's great. I mean, that's really interesting to hear all of that. And I think I love that you broke it up into first, second, and third trimester, and there's different physiology in all the trimesters. And if I heard you correctly, it sounds like you're not quite as strict on the carbohydrates in the first trimester. And then as they progress in the second and third, you might recommend to some of them to lower the carbohydrate amounts based on how they're doing in terms of insulin sensitivity. Is that right?
So when we talked about all these nutrients, right, that you need for pregnancy. So the one thing we look at is how do you get these nutrients? And you get these nutrients by eating animal, nutrient-dense animal foods. And so, across the board, it's mathematically impossible to eat 50 to 60% carbohydrates and get all of those nutrients that we just talked about. I mean, it's just mathematically impossible. Now, a lot of people will say, okay, well then how many carbs should I eat per day? And I think it's very individualized. When we look at the data from the Institute of Medicine, who actually comes out with these recommendations on how much fat, how much protein, and how many carbs a woman should eat, it's interesting because when you look at the recommendations for fat, for instance, the Institute of Medicine says there's no defined intake level at which potential adverse effects of total fat have been identified, meaning there does not appear to be an upper limit on fat, right? But they set a minimum, okay? And we've talked about the types of fat that women eat. Okay, so then let's look at protein. The Institute of Medicine says there is no defined intake level at which potential adverse outcomes of protein have been identified. So essentially there's no upper threshold for protein. But we do know that there are adverse outcomes if you don't eat enough protein. And the recommendations for women are too low, in my opinion. The recommended daily allowance is somewhere around 71 grams per day. But really, studies show that the use is higher in pregnancy, and women probably need 1.2 grams per kilogram per day in the first trimester and 1.6 in the second and the third trimester. So if you calculate that for an average 150-pound woman, I mean, we're talking at least probably 110, 120 grams of protein per day. And if you break that up into 3 meals, that's 30 to 40 grams of protein, which is exactly what I tell women to eat with each meal. Then when we look at carbohydrates, right, we're telling women to eat 50 to 60%. This is from the Institute of Medicine. I'm reading this straight from them. 2002, the lower limit of dietary carbohydrates compatible with life apparently is 0, provided that the adequate amounts of protein and fat are consumed. So we essentially can make all of the carbohydrates that we need through a process called gluconeogenesis and breaking down our own glycogen. So then where do we come up with this number? Because the number when I came into practice was to tell a pregnant woman to never eat less than 175 carbs. So that was set as the lower limit, 175 carbs. And when we look at glucose oxidation in pregnancy, maybe there's studies that show that women utilize probably around 280 grams per day, maybe 210 if they're breastfeeding, but we can make upwards of 200 grams of glucose per day through using amino acids, through using glycerol from fat, lactate, pyruvate, acetone, all the substrates we use for gluconeogenesis. So where does this number of 175 carbs come from? So we look at the obligatory use of the mom, right? So we have organs of obligatory use that need glucose, like our brain. And that's about 70 to 90 grams per day. And then they took 2 standard deviations. And so they came up with about 130, right? This is statistics. And then they looked at the obligatory use of glucose by the fetus. So the baby's brain, which was like 20 to 25 grams. And then they added about an extra 30 grams because the woman's pregnant. And so she weighs more, she has more use. And that's where they basically rounded up and they came up with 175 grams. But when we look at pregnant patients, I find that that's too much for some patients. Sorry, I have a child in here now. Thank you. Okay, go read a book. Real life over here. And so, in my opinion, for some patients, especially who are obese, insulin resistant, 175 carbs, that's a lot of carbs. And you break that up into 3 meals. I mean, that's eating 50 to 60 carbs with each meal. That's basically at our max efficiency of use of glucose, like at a meal. And so it really needs to be individualized. I think the threshold is way lower. Now, does that mean that patients should eat 0 carbs? You know, there are some carbs if you're eating nose to tail, right? You're getting a few. But as long as a woman is getting adequate nutrients, I don't care if she eats a few plants. You know, I don't care if she's insulin sensitive, if she eats some carbs. And I know you have theories around that with polyunsaturated fatty acids, but I definitely think that when we say do no harm, telling a woman that she has to eat 175 carbs, you know, could be harmful for the pregnancy, especially based on the data that we see from things like the HAPO trial, which is the hyperglycemia adverse outcome trial, and the HAPO follow-up trial. There are epigenetic changes that happen in these babies if women eat too many carbs in pregnancy. But protein and fat seem to be fine.
And I completely agree with that. I think that the main issue with carbohydrates for a lot of these women, well, there's probably 2 main issues from my perspective, is that they're eating them at the exclusion of other more nutrient-rich foods. And a lot of carbohydrates are not super nutrient rich. You know, glucose, I think, has a role in human metabolism. I think ketogenic states and low carb states are super helpful as well. But I think that, you know, telling someone to eat 55% of their calories is carbohydrates, like you said, I 100% agree with you. There's no way that we can get enough nutrients in other ways. Personally, I found that including some low toxicity carbohydrates back in my diet, moderate amounts, 100 to 150 grams per day, has been helpful for me. But if I go above that, I'm not going to be able to get enough meat and organs, which I know are where I'm getting the nutrients that really run my body. So for me, there's a balance. And I love that you said it's kind of individual. And for these women, I think it can be as well. But yeah, I would agree also that suggesting to people that 175 grams a day is the bottom end is, how are you going to eat anything else? These, you know, unless the woman is like an Amazonian woman and they're getting lots of calories, that's going to be hard. It's going to push out the more nutrient dense meat and organs. Let's talk about delivery, postpartum, lactation. A lot of women think like, what should I do during lactation? Again, I think we're going to see a lot of the same themes come through. Do you want to talk about that? Is there anything else you'd like to add for pregnancy? And then we can move on to that.
Yeah. Okay. So we talked about this transition when a pregnant woman delivers, and we know that babies are essentially, ketogenic in the 3rd trimester. And we know that the babies are actually making their own ketones because we've looked at studies where we look at the fetal cord blood versus the maternal blood, and babies actually measure usually around 2.0 millimoles, whereas the maternal serum levels are typically around 1.0 millimoles. But actually, right after birth, probably within 12 hours after birth, we see the sharp increase actually in ketogenic enzymes, along with an increase in free fatty acids in the baby. And that's because human babies, we have large brains. This is how we're different than other mammals. We have these big brains, and we need lots of fat and cholesterol. And these ketones actually are important for myelination of the brains and for fetal development. And so term infants actually show very vigorous levels of ketogenesis, and it's a very important part of transition to extrauterine life. And I think it was an adaptation and a survival mechanism for us as mammals. But breastfeeding itself is very ketogenic too. So basically, once lactation is really active, the breast milk is very rich in fatty acids. And the fatty acids go down into the baby's gut, and there is intestinal hydrolysis of these milk fats, and they get directly absorbed without passage through the lymph system. And this is once again super important for babies' development. Now, for people to say, so what should I eat when I'm breastfeeding? Well, the same nutrient-dense diet that you ate in pregnancy is also important for breastfeeding. But the change with breastfeeding is that you do need a lot more calories. So in pregnancy, you probably only need in the ballpark of like 1 to 300, but for breastfeeding, you need upwards of 500. And so the most important part, especially for women who are low carb, is that you're getting adequate calories. So with that being said, a question I get a lot, people will send, messages through social media and things like that. And they have the baby and they weren't eating well, and now they're breastfeeding, and now all of a sudden they want to like go carnivore or go low carb. And this is probably where we need to be a little bit cautious, because as you know, because you understand physiology really well, but for everybody listening, is that when you have a dramatic reduction in carbohydrates in the diet, if you go from eating 400 carbohydrates to eating 25 carbohydrates, you're going to have a period of essentially dehydration, electrolyte imbalance if you're not adapted, and usually a reduction in appetite. And that's a problem if you're a breastfeeding mom, is we need to maintain your appetite and calorie intake. So if you are interested in all of a sudden cleaning up your diet and eating less processed carbs and things like that, I recommend to just take it easy, take it slow, make sure you're managing hydration and electrolytes. But there was a 2009 study that actually looked at breastfeeding women, and they looked at low carb, high fat versus high fat and, low carb, high fat and high carb, low fat. And what they found was that there was more fat in the breast milk of the women who were eating less carbs and more fat. And fat is so important for your baby's development and brain development. But there was better weight loss for moms. So the moms who wanted to lose the weight actually lost more weight eating less carbs and more fat. And then their babies were getting more fat and more nutrients. So, and the protein and the carb content of the breast milk did not change. So the only thing that changed in their breast milk was the fat content. And it basically was coming from the mom's fat stores. So you want to take the fat off your body and put it in your baby's cute little squishy body, that's a great way to eat. But breast milk is amazing. So breast milk is a superfood. So not only is it giving your baby all these super important nutrients, but it's been so fascinating what they find in breast milk. There's actually these complexes that are like, can kill tumors. And that's probably a survival mechanism, right? So your baby doesn't get cancer. But when we look at what should be in your diet, a big one is choline. So choline is super important for your baby's brain development. And we know that that is statistically hard to get if you're not eating nutrient-dense animal foods, meat and eggs and things like that. And then B vitamins, we talked about how those are important in pregnancy. In breastfeeding, those are directly proportional. The dietary amount that you're consuming is directly proportional to what's in your milk. So those are super important to be getting. Fatty acids and DHA, direct correlation, like I said, with the quantity of fat in the breast milk compared to what the mom is actually consuming. So you want the mom to be consuming good amounts of fat in the diet. Vitamin A, we talked about vitamin A earlier, and I said how this was not only important in pregnancy, but super important in breastfeeding women, because it affects infant growth and it affects the infant immune system. So babies are born with basically no immune system. And it's a lot of the immunoglobulins and things like that. And then things like vitamin A that help with your baby's immune function. And in the first 6 months of your baby's life, they need almost 60 times the amount of vitamin A compared to the whole 9 months of pregnancy. So when we look at vitamin A needs, big time important with breastfeeding. And colostrum, which is the first kind of type of milk that comes out of the breast, is super rich in vitamin A. So if you've ever seen a woman pump out colostrum, it's got that really deep yellow color, like we compare egg yolk colors. And that's because that colostrum is super rich in vitamin A. And then iodine. Iodine is super important for your baby, and iodine intake in the woman is directly correlated with the amount that's in her breast milk. And what's interesting here, when I was looking at the iodine needs and I did a post on this actually not that long ago, but one thing that I commonly encounter and that I had myself personally was postpartum hypothyroidism. And I think that mine was likely a combination of insulin resistance and probably some iodine deficiency. I had like 3 pregnancies in 58 months and breastfed all my babies. And I wasn't eating, that much shrimp and other sources and beef and other sources of iodine, eggs in my diet. So that's super important. But what's also interesting is, remember how we talked about people who abuse carbs in pregnancy have issues. Well, those women, so let's take those women who maybe they even passed the test, right? And they weren't gestational diabetic. Maybe they failed the 1 hour test and passed the 3 hour. But those women who are insulin resistant, those mothers have higher amounts of glucose and insulin in their breast milk. And their babies, by breastfeeding them, they're actually increasing their risk of insulin resistance, obesity, and diabetes long-term in their babies. Now, I'm not saying you shouldn't breastfeed your babies, because breast milk has really amazing things in it. It has actually kind of its own little form of fiber, like these oligosaccharides. It has endocannabinoids. So it has amazing things in it. You should for sure breastfeed your baby. But the short of the matter is that the same nutrient-dense diet in pregnancy should be consumed in a breastfeeding woman, but with more calories.
I love it. And I love that you emphasized fat and the importance of women getting enough fat, and especially the animal fats, which are rich in all these things. We've talked about vitamin K a few times. There's vitamin K in animal fat, and we don't really think about this, but vitamin K is a fat-soluble vitamin. And the other thing you mentioned that was interesting for me is that if you look at the way that synthetic formulas, which I'm no advocate of, are made, they have a lot of linoleic acid in them, because a lot of women's breast milk, when they are surveyed, have higher amounts of linoleic acid. And you pointed to the reason for this, that breast milk is being made from a woman's fat stores. And I've talked about this in the past. If we are eating excess linoleic acid, that is stored. Humans don't make linoleic acid. We store excess polyunsaturated fats. So one of the concerns I have for a lot of women in our society is that throughout their whole life, in the prenatal period, during the pregnancy, they're getting too much linoleic acid. They're storing too much linoleic acid in their fat cells. And then that linoleic acid is going to come out in the breast milk for the baby. And then baby gets excess linoleic acid, which has both consequences from an oxidative stress perspective and also consequences from, I believe, a adipocyte hypertrophy perspective and a metabolic dysfunction perspective. So, I think it would be so interesting for the mothers who can't breastfeed to make an actually physiologically better formula. Oh, your daughter's in the background. That's so cute.
She's 5, but she's making laps.
If you guys are not watching, you should watch this on YouTube. We have a cute child transiting in the background here. But I just think that the amount of linoleic acid in formulas is too high, because women's fat stores are full of linoleic acid. We can accumulate this, guys. Not a good thing at all.
Yeah, when I was breastfeeding my girls, I only had 4 weeks of maternity leave with each pregnancy. That's just how it worked, because I was in medical training. And when I needed to supplement, I actually had like huge supply issues, because it was very hard to like pump in adequate amounts when I went back to work, because pumping is not as efficient as a baby is. And I had to supplement, and I was terrified, because I would flip over these baby formulas and it was like glucose syrup solids and like canola oil.
Soybean oil.
It was like, that's what's in, that's the best we have. Like, it's whatever, what year it was. Let's see, I had my baby in 2011. I'm like, this is the best we have. But now it's been amazing, because the hospitals that I work at, they use donor breast milk as first line therapy, which is just amazing. Thank you for all those women out there that donate your breast milk. For these babies, especially for the premature babies, that we deliver and take care of, because there really are amazing things in breast milk. And I'm not trying to shame any women, because there is a lot of reasons why sometimes people have trouble with breastfeeding, but I think some of it too is inadequacies in our diet, and nutrient deficiencies and insulin resistance, and things that we could probably fix that could help more women, breastfeed better or longer.
Absolutely. And I love that you mentioned colostrum also, because that's this rich, immunoglobulin nutrient first milk. And at Heart and Soil, we're coming out with a colostrum supplement soon, which is not necessarily for babies, but it'll be for humans that are interested in getting that support from grass-fed cows. So that's an exciting thing too. But obviously that first colostrum from healthy moms is critical. So, okay, so we've talked about infertility, prenatal, pregnancy, delivery, breastfeeding. The thing that we didn't get to in the first podcast that I got so many requests for was, let's fast forward a little bit. Women get to live their amazing lives with their children, walking in back of them during podcasts and making them laugh during podcasts. Let's talk about peri-menopause a little bit, and then we'll wrap up so you can go hang out with your kids today. Because this is something that I know you think about also, and I know there are perimenopausal or women who have already had children listening to this as well. So what do you think about perimenopausal, the menopausal transition in terms of nutrition or other types of support?
Yeah. So if you go back to the way beginning of the podcast, we talked about how women go through their years, they go through puberty, and then they go through these years of fertility. And then they go through something called peri-menopause, which I like to kind of call reverse puberty. So remember how we said that basically every single month, the pituitary gland in the brain is sending out these messengers that's going into the room, and it's saying like, hey, I need 20 of you to come to the party, right? And then it's picking out the best one. Well, what happens is as that pool of eggs starts to decrease, there's less people in the room. There's less people to invite to the party. And so every single month, there's less people that are being invited, and each person that comes to the party brings a little bit of estradiol or estrogen with them. And so what's happening is we're starting to see very erratic levels of estrogen secretion. So if I drew everybody a map of what estradiol levels look like in perimenopause, it would look like a roller coaster ride, like you're at a theme park, an amusement park. One month it's like 200, the next month it's 20, then it's 175, then it's 80. So it's all over the place. And so we see these erratic levels of estradiol. And as we see this kind of slow over time, it is going down, all the way down. But as it's going down, we're also seeing decreasing amounts of progesterone production from the ovary. And so progesterone is a hormone of pregnancy. It's a hormone that supports an egg until it gets fertilized and implanted. But what we start to see is relative estrogen dominance as women become perimenopausal. And it can cause a variety of symptoms for women. So this is where women start to experience very irregular periods. They might start missing periods. Their periods might get heavy. They see changes in thyroid function. They see changes in their hair. They start to have trouble sleeping. They get brain fog problems. I mean, perimenopause and menopause can be horrible. The clinical definition of menopause is essentially when you haven't had a period in 12 months. That's considered to be menopause. And that's when the brain is like screaming at the room, like, I need people to come to the party. And there's nobody that wants to come to the party. The room is empty. There's essentially no eggs left in the reserve. Remember we said you're born with all the eggs. Now this is a natural thing. You are guaranteed 100% that at some point in your lifetime as a woman, you are going to go through menopause. So the question then being is, what do we do to help these women make this transition and have less symptoms? And so when we look at the symptoms that they have, one thing that we see is as we see this reduction in estrogen and estradiol, there is an increase in insulin resistance and an increase in visceral fat deposition. So from a lifetime risk perspective, the things that are most likely to kill you or make your life miserable, cardiovascular disease and diabetes, this transition is where if you're abusing carbohydrates in the diet, you're going to have a very rough transition as you lose this estrogen and become even more insulin resistant. And you're going to see a marked increase in your risk of diabetes and cardiovascular disease and dementia. Neurologic diseases, we don't hear about them a lot, but your brain is going to start working way less efficiently. And I hear every woman say it. And then the one thing every woman says is, doctor, I'm eating exactly what I ate for the last 10 years. And all of a sudden I gained 15 pounds. It's like overnight, I gained 15 pounds. I hear this all the time. And so dietary strategies are extremely important for these women. I like to talk to them about reducing polyunsaturated fatty acids, which are very inflammatory, like we talked about. And reducing carbohydrates in the diet. So these two things are dietary strategies that I use that help patients with this transition. Intermittent fasting can be another great tool for these women because even without a reduction in dietary carbs, we know that intermittent fasting can reduce fasting insulin levels by about 50%. So this can be a great tool for these women. And the unfortunate truth is that they need less calories in their diet. As women age, they lose about 10% of their lean body mass unless they're eating lots of protein and nutrient-dense animal foods and lifting heavy weights. So that's why I'm a huge fan for every woman out there listening in your 20s, 30s, 40s is to eat meat and lift heavy things, because if you want to fight against some of these perimenopausal changes, having extra lean body mass as you make this transition is going to help fight some of these natural physiologic changes that happen. Other things that we have to consider is things like coffee, tea, and caffeine, because part of our estrogen metabolism, like we talked about, that happens in our liver, things like excessive amounts of polyphenols, and I've posted about this before, or caffeine can slow that down. And for people that have relative estrogen dominance, that can cause issues. Your gut, your bowels aren't working well. We talked about how estrogen can get reabsorbed. And especially postmenopausally, this can increase our risk for estrogen-related cancers. And so it's super important. I actually did a YouTube with Kelly Hogan. We talked a whole hour about perimenopause, and people loved it because it's something that doesn't get talked about. But I think that people who are low carbon carnivore actually tend to transition through this phase with a lot less symptoms, and don't tend to experience a lot of the side effects. With that being said, hormone replacement therapy, a lot of people in this kind of low carb carnivore realm, right, hate doctors. They're evil. They're just like pushing pills. But hormone replacement therapy can be a good option for a lot of these women. And I like to think of it more like biohacking than using a medication necessarily, because there's pretty good evidence for protecting our brain and our heart and our bones, especially within 10 years of menopause. And for the patients that are doing the right things, like eating right, moving right, sleeping right, decreasing toxins and stress in their world, those are the perfect candidates for hormone replacement therapy. And so these are things that I think women should think about as they make this transition.
And I know that in my practice, a lot of women are interested in bioidenticals versus, other hormone replacement therapy. Do you have any thoughts about bioidentical hormone replacement therapy versus quote unquote standard hormone replacement therapy?
Yeah. So first of all, bioidenticals does not necessarily mean natural. So a lot of people think that bioidenticals means like that it's natural, that came from nature. So there are bioidentical hormones that are still synthetically made, and vice versa. Okay, so let's like dispel that for just a minute. Where the controversy comes with quote unquote bioidenticals is actually with compounded bioidenticals. So when I write a prescription for somebody to go to the pharmacy, because that is standardized, I know exactly how much, even if it's a bioidentical hormone, I know exactly how much, 17-beta estradiol or estriol or progesterone that they're getting. When we compound something, when we take like a little jar and we put a certain amount of estrogen, progesterone, testosterone, or whatever in it, and you take a scoop out of it, let's say it's like a cream or a gel, you don't necessarily know in this scoop if it's the same amount as the second scoop, as the third scoop. And you really have to trust your compounding pharmacist that your formulation is correct. So that's where the controversy it's really more with compounded bioidenticals more than anything, not necessarily bioidenticals. But the reason that people, prefer bioidenticals is people will argue that it still turns the same lock, essentially. It still kind of like inserts into the same receptor and whatever. But obviously, things that are more natural to what our body actually makes, there probably are some differences. Now, the important thing with hormone replacement therapy is that you are actually metabolizing these hormones in a safe way. So we talked about estrogen metabolism. So when estrogen, whether your body's making it on its own from your ovaries or whether you're taking it as a hormone replacement therapy, your body still has to take it to the liver and it still has to metabolize it. And so we talked about phase 1 and phase 2 estrogen metabolism. If you're not eating a good diet with things like magnesium and B vitamins, your metabolism of estrogen could be sluggish. And then you put on top of that, use of, let's say caffeine and tea and coffee and alcohol and all these other things that your body has to metabolize. And it could be even further sluggish. So I kind of like think about it like a bathtub, and you're pouring estrogen in the bathtub, but there's a drain at the bottom of the bathtub. And you could be pouring more into the bathtub than you're able to drain out. And that's going to exacerbate symptoms of estrogen dominance. You're going to get heavy periods, you might get fibroids, you might get growths in the breast. And of course, one of the metabolites of estrogen can cause DNA damage and increase the risk of estrogen-related cancers. In women, that's breast cancer, and in men, that's prostate cancer. So men don't think about it. Can you go do your magic spells out there? Yeah, she's got magic spells. Maybe she can put a spell on people eating too many PUFAs for you, Paul. But for men too, I want you to hear this, because men go through andropause, and a huge issue, and we could tie this back to the infertility, is that men these days are so insulin resistant, and insulin, hyperinsulinemia in men increases aromatization of their testosterone into estrogen. And if men aren't getting rid of their estrogen in the right way, it increases the risk of prostate cancer. So this is important for men too. So listen up if you've tuned out about all this women and pregnancy stuff. But that's why it's so important as we make this transition that we're doing the right things in our diet and in our, sleep and movement and all of these things that you and I talk about all the time.
Amazing. A couple of things that you were talking about that I want to just highlight for people and emphasize. So Jaimee is saying that polyphenolic compounds, methylxanthines, caffeine, these can actually sort of gum up the detoxification, quote, works in the liver and prevent the normal recycling and exportation of estrogen. These are not good things. And that's a very counterculture sort of statement. It's something that I've talked about in my book, The Carnivore Code, but basically lots and lots of these methylxanthines, lots and lots of these polyphenolic compounds can affect the way we are metabolizing these things in a negative way. And like Jaimee is saying, there are multiple breakdown products of estrogen. There's 2-hydroxy, 4-hydroxy, formulations or, sort of isomers of this breakdown product of estrogen. And some of those can contribute to problems for both men and women. And I love that you highlighted this. The wrong types of breakdown products of estrogen can lead to prostate cancer. A lot of men think it's just too much testosterone, when in fact it could be the wrong type of estrogen, which is happening because you are metabolically broken, because you have metabolic dysfunction, because you have issues with your underlying metabolism at a basic level. We've got an amazing sort of necklace happening here in the background. But nevertheless, I think it all kind of ties together. And the theme that we're really getting to over and over is be metabolically healthy. How do you know if you're metabolically healthy? You get basic labs, you get fasting insulin. Jaimee said, nobody ever checked her fasting insulin. You get fasting glucose, you get hemoglobin A1C, you wear a CGM. I think a continuous glucose monitor from something like NutriSense, there is no better way. That is basically, you are able to do an oral glucose tolerance test on yourself every single freaking day with a CGM. And so if you don't know if you're metabolically healthy, look at your waistline and do some basic labs, but don't let your doctor not look at these things in you and know how to correct this. Limit carbohydrates, limit polyunsaturated fats. This will change your life. It's all connected in such a basic way. And the ramifications of having underlying metabolic dysfunction are profound and so bad, and they're myriad. We've talked about magnesium a few times. I just want to add that I think a lot of magnesium deficiency, and you mentioned this earlier, is due to insulin deficiency or insulin resistance, excuse me, that in the state of metabolic dysfunction, quote, insulin resistance, we are wasting magnesium. And as you said, magnesium deficiency can exacerbate metabolic dysfunction, insulin resistance, and I think it goes the other way as well. Metabolic dysfunction, insulin resistance causes magnesium deficiency. One of the questions I get a lot is, where do you get magnesium on an animal-based diet? If you really look at human nutrition, you don't really get magnesium a whole lot of places. Meat is a decent source of magnesium. I think it's more about how much magnesium you retain than the absolute amount of magnesium you take in. Spring water is a good source of magnesium. I think the majority of our magnesium might have come from water and things like this. There's no really good sources of magnesium in the plant kingdom. Meat is not a bad source at all, over 100 milligrams per pound of meat. And I think the key with magnesium is not that we are not getting enough of it. Some people certainly may not be getting enough of it if they're making so much of their diet as carbohydrates. But if you're eating meat and organs, I think you're getting enough magnesium, and you will retain it if you are insulin sensitive and metabolically healthy. Would you agree with that? What are your thoughts on that?
Yeah, 100%. And we think of things like bone broth. There was another, I hate to segue off of magnesium, but another thing I want to talk about for pregnancy, especially for nose to tail, is glycine.
Yeah.
So bone broth is a great source of glycine in the diet, along with, B vitamins and protein and iron and zinc and those things. But glycine, thought as a non-essential amino acid in pregnancy is actually essential. The fetal needs, because of the making your baby's DNA and just the excessive amounts of collagen that we need in pregnancy, glycine is actually essential. The maternal needs are huge. So the uterus, we're talking like becomes 800% the volume that it normally is. And there's an increased need for collagen and glycine. And stretch marks are actually thought to be caused by not enough glycine in the diet. And that's a huge thing that like every woman asks about, right? And so when we look at glycine versus methionine in the diet, if you're not taking in enough glycine and you're eating excessive amounts of methionine, it can raise homocysteine levels and it can increase the risk of things like preeclampsia, preterm birth, neural tube defects, and miscarriage, first trimester miscarriage. And so we need to make sure that we're getting that in the diet, and we need to make sure that we're getting choline in a diet, because choline can be converted to glycine, but we don't want to be wasting all of our choline making glycine. So.
And choline is in liver and egg yolks. Those are super rich sources. I love that you dropped that bomb about glycine and stretch marks. That is going to light the internet on fire. That's amazing. Anything else you want to talk about as we wrap up? Should we get your daughter on the podcast to say hi?
Kimber, you want to come say hi? Come say hi to the world.
She's going to be famous.
My third one. She's my favorite. The other two big girls are at school. So it's real mom world over here.
Anything else you want to talk about as we wrap up? Or I think we've talked about so many great things.
Yeah, no, this is amazing. I guess the only other thing is the other thing that pregnant women are told not to eat is fish. And I encourage my pregnant women to eat fish. It has lots of good nutrients in it. And if they like sardines, eating with the bone in helps, you know, but calcium needs actually don't go up all that much in pregnancy. But the important thing about fish is that I was going to say is we tell pregnant women not to eat fish because of risk of mercury. In Nebraska, the highest mercury containing fish, maybe tuna, but we don't have like swordfish and king mackerel and things in Nebraska. But selenium, the selenium in fish actually helps bind the mercury. And so, and fish also contains zinc and iodine, which are super important. And so I encourage pregnant women to eat fish. We tell women 12 ounces per week, and I don't know a lot of people eating more than that. And then dairy is another, controversial one. Like I said, you can get calcium from eating sardines, from eating the bones, but dairy is also an important source of K2 in the diet. And you can eat things like kefir, like fermented dairy and things like that. And it does help with bone health and with insulin sensitivity in pregnancy too.
Yeah, I think things like dairy, colostrum can be helpful if people are not sensitive to the proteins in milk. Just know if you're sensitive immunologically to things like casein and whey. So that would be the thing. So I think, in summary, it just sounds like, gosh, like animal-based nutrition, like our animals have been eating, eat nose to tail, get the organs. If you can't get the organs, get desiccated supplements, don't overeat carbohydrates. And I love it. This has been an amazing podcast. I think women and men are going to benefit so much from this. Future Miss America right here, Jaime Seeman. Thank you so much. Where can people find you and support your work?
Yeah, you can find me on social, Dr. Fit and Fabulous on both Instagram and Facebook. I've got a website, drfitandfabulous.com.
Cool. And what is the most radical thing that you have done recently, Jaimee?
Well, winning Mrs. Nebraska was honestly the most radical thing I've done, because for anybody that's listening, I have never in my entire life, swear to God in my life, I've never done a beauty pageant. And I'm an athletic build. Like, I'm not the person that you would normally see up there. And for me, my kind of like theme of this last week has been suck at something. So I encourage everybody to go out there today and do something that you suck at. And because when you try things that you're not good at, that's when you get physical growth, you get mental growth, you grow in your life when you try things that you're not good at. And so try something this week that you suck at. And I went for it and I won. And so we're not stopping here. We are fully preparing to win Mrs. America.
When is the Miss America pageant? This is amazing. I love it.
In Las Vegas. It is January 22nd through the 29th. Of course, if COVID doesn't ruin that, but it's coming, a couple months away.
You guys heard it here first. Future Miss America right here, dropping knowledge bombs, helping women have conception and fertility and breastfeeding and perimenopausal. Amazing. Thank you so much. I appreciate you. I can't wait till we talk again.
Thanks, Paul.
All right, you guys. Thanks for listening to that podcast. Thanks to Jaimee for coming on. She is an amazing woman, and I really think it's awesome that we got to talk about all this stuff for ladies. So like I said, this one is for ladies and the men and women who love them, because it's really cool. If you are interested in more content for ladies, I did a previous podcast with Jaime Seeman. This is the second one. And I did a podcast with Elle Russ. I've done 2 with Elle Russ on thyroid. Men get thyroid issues too, but I talked about it with Elle twice. And I had a podcast with Karen Martell on weight loss for women. So I've got a little mini library of stuff that is specifically aimed at women listeners, but all of it is relevant for men as well. So check that all out. You can go to heartandsoil.co under the Learn tab. You'll see all my podcasts and all my videos. Like I said, you can go to heartandsoil.co. You'll see the JRE, Joe Rogan Experience. Show notes there, all the stuff I talked about and a lot more. And at Heart and Soil, we've got beef organs coming back in the next week or so. Sign up to be notified, or check out Lifeblood, Histamine and Immune, which have a lot of the same organs and are great interim products if you're missing beef organs, but it's going to be back real soon. And we have Heart of the Warrior, which is heart and liver coming, as well as a grass-fed, grass-finished that is very rare, colostrum, which will be awesome for those with GI issues and overall immune issues who tolerate dairy. So lots of cool stuff happening at heartandsoil.co. You can also sign up for our newsletter there. It comes out every Sunday. I write it myself, all the cool science and things I've been thinking about for the week. Please check out the sponsors, sacredhunting.com/Paul. Like I said, I love Monsell. I love what he does with these hunts. This will be, I believe, for many of you, a game-changing experience. You will really enjoy this. You can do bow or rifle. You can check out Chili Pad at Chili Technology, CHILI technology.com/carnivore-MD. I love my Uller. I love my Uller. Have I said it? I love my Uller. They make good stuff. It really helps me sleep better. Check them out. WhiteOakPastures.com. Great people. Belcampo.com. Amazing meat from both of these farms, from regenerative farms, organs, suet, all kinds of good stuff there. And Blue Blocks, BLUBLOX.com. BLUBLOX.com. Blue Blocks. So what is going on with me? We got a lot of cool stuff happening at Heart and Soil. I am finishing up writing the cookbook. I went to White Oak to take photos, some of which you guys have seen on my socials. A lot of fun times outside recently. Got out on the lake on my foil board, which is cool. Austin is cooling down. I love the fall. I'm going to get out hunting. I haven't been able to yet, but either this weekend or next, I'm going to be out there hunting, and maybe I'll post a picture of an animal if I am fortunate enough to harvest an animal respectfully. And that's what's going on with me. Thank you guys for being a part of the remembering. This is really something that is valuable for me, that is meaningful for me, and I'm grateful that you find this content valuable. So please share it with someone in your life that could benefit. And remember that nose to tail eating is a major part of this. The beginning of all of it is a stepping stone for people, but it's just the beginning. It's about how we live and share this life with people in it and do things that are meaningful to us. So check us out at heartandsoil.co. If you need more nose to tail nutrition in your life, and I love you all, stay radical. Next week's podcast is with Tucker Goodrich. It's amazing. It's freaking amazing. We talk about linoleic acid. It's amazing. You guys will dig it. Stay radical. Talk to you soon. You can send me an email, drpaul, drpaul, heartandsoil.co. If you have product questions, if you have questions about the carnivore diet and how to do it. I can't be your doctor through email, and I can't do labs through email, but I will help you and tell you what product will be best for you and help you construct a nose to tail diet in the best way I can. Shoot me an email, drpaul, drpaul, heartandsoil.co. All right, you guys, until next week, stay radical.